Good morning and a very warm welcome to you all. My name is Nens van Alphen. I'm an associate professor of neurology and I'm the local host and organizer of the 2021 online ICCNMI course and conference. We are very happy to announce that we've made a very special addition to this conference with the help of Cadwell, who have sponsored and taken care of a very interactive live demo session in 3 continents of the world for you. You can find out more on this webpage, which also has the access link for all 3 sessions that you might want to attend. These are free live online demos and with an interactive component, so you can ask anything you like and your local host will try to show this to you. Here are the sessions. We've set one up in Asia, coming from Singapore. We've set one up in Europe for you, coming from Rome and Italy. And we've set one up for the Americas, coming live to you from Sao Paulo in Brazil. All the sessions are geared towards your lunch hour in the local time zone. Obviously, you can also watch them from other parts of the world. Now let's see our speakers. We've got 3 renowned hosts who are very experienced neuromuscular ultrasound scanners themselves. In the Asian session, Dr. Joy Vijayan will come to you from Singapore, demonstrating you his techniques and take on neuromuscular ultrasound. In Europe, we've got the honor to meet the founding father of the ICCNMI Society, Luca Padua, who will teach you from his office in Rome everything he knows about scanning. You can just ask him for any special tips and tricks. And finally, in Americas, Dr. Ana Lucila Moreira from Sao Paulo, Brazil, will be your live host and show you any technique that you might want her to demonstrate. Incidentally, she will also be the next year's host of the ICCNMI 2022 event, so please watch out for that as well. So join us for these free live demos brought to you by the ISPNI in cooperation with Cadwell. You can access them from these links below. If you're interested, you can also still subscribe to the full conference, and the digital material will also be available offline after the event ends. We sincerely hope we can meet you there, and happy scanning, everybody.
Ok, posso parlare? Ora però c'è lo schermo. Io non mi vedo, non importa. Ok. Hello to everybody. First of all, I would like to know if you can put in the chat your experience about a nerve ultrasound, so I can modify my presentation and the demonstration on the basis of your experience. So if you, I start from the first step of the ultrasound, but in the meanwhile you can write on the chat if you have experience or not. So we go forward or not. So what we have to do in a case of a nerve ultrasound. This is the probe, high frequency probe. I put the gel and I can study the nerve, but I have to know very well the anatomy. Che mi metti lo screen, questo? Il PowerPoint già ci sta?
No, devi cliccare su, glielo faccio.
Ok, intendevo l'altro. Ok, so first of all, we put the probe and we see several structures. Some of them, most of them are muscles. Here, this is an artery. This is the bone with hyperechoic. This is a muscle. And we recognize this structure between the superficial flexor digitorum and the deep flexor digitorum. This is the median nerve, and we see black dots that are the vesicle of the nerve. So we can follow, but we have to know the anatomy very well. So we start from the arm. Here you see the median nerve, and the median nerve is in this position, and the median and the ulnar are close, and we are just medially to the biceps brachii. Loro vedono il PowerPoint, giusto?
No, lo sta vedendo, cosa sta facendo lei? Devo fare vedere il
Sì,
PowerPoint.
sì. Okay, so here we have the median and the ulnar nerve, the biceps brachii. We are at this level. Here we have also the brachial artery, the veins, the triceps, and we can see very close the median and the ulnar. Possiamo vedere il... Sì. Okay, so here is we see a nerve, as we said, it's with the black dots, and we can follow, and we can understand which nerve on the basis of the course. This is a muscle. This is the biceps. Contrai il bicipite. You see the movement. One of the major advantage of ultrasound is the possibility to have a dynamic evaluation. So during the movement of the joint or contraction of the muscle. So we are here and we see two nerves, and we can follow one nerve and the other nerve. This is the ulnar, because you can see the position of the probe. And here, more anterior, we have the median nerve, and we can follow. Okay? So first of all, faccio da solo. We have to know very well the anatomy. We have to know the anatomy, as I said. This is in the arm, and this is close to the elbow when the median nerve is or goes in the cubital fossa, and is behind the lacerto fibrosus here. In this position, usually the nerve is not well depicted. And then we go in the forearm, where we just saw the flexor digitorum superficialis and the flexor digitorum profundus. So let's go to the... Okay, so let's start. Every examiner can decide from where to start in studying a nerve. Usually I prefer to start the median nerve in this position, where it's very clear under the superficial flexor digitorum and above the deep. You can see here. Every time you see the nerve, you can adjust the focus. The focus is the level in which there is the back depiction. Okay, so we go proximally. Here, as I said, it's less depicted. Here, and we are going close to the elbow, and then we are going in the arm. Here is, and here is the ulnar nerve, and we are going close to the axilla. Okay? So, no main branches of the median nerve at the arm. We go distally again. This is the humerus. Okay. This is, we have to change the angle of the probe, otherwise we don't see the median nerve. You see, if I have the probe in this position, I don't see. If I change the angle in the way I am perpendicular to the nerve, I see the nerve, and is going in the forearm. Okay, and now we are again between the deep and the superficial flexor digitorum. As you can see here, the nerve is close to the bone. And this is particularly important in supracondylar fractures in the children. Possiamo mettere...
Sì, aspetta un attimo.
I would like to know if someone wrote in the chat about the experience. I'm looking for supracondylar. Obviously, I don't. Okay, perfect. I don't see. It's very strange. It should be. Here is. This is a paper in which we describe two cases of supracondylar humeral fractures. In one, we had strict monitoring because we saw that the median nerve was in continuity, and after an initial deficit of the median nerve, the patient, we didn't suggest the surgery, and the children improved. On the other side, we saw that the median nerve was under a bone fragment, and it was operated on. So, as I showed in our subject, mi dai il coso? Okay. The median nerve is close to the bone. Here, mainly in children, we may have damage due to humeral fracture. Going back to the forearm, here is, we adjust the focus. You see the black dots of the fascicles. And now we are going toward the carpal tunnel. Here we see the tendons of the flexor digitorum, and the median nerve is above. How can we distinguish the tendon from the nerves? Yes, changing the angle of the probe, we see that the tendon modify from hyperechoic to hypoechoic, while the median nerve, the nerve, is always with the same pattern. Here we are in the canal. I need more gel. Here is. This is the transverse ligament. This is the median nerve. These are the tendons. You see the changes from hyperechoic to. We are going more deep, and it's normal that here the nerve is more flat because it's dividing into the different branches. Here the tendons, sorry, here the different branches. This is a new tool merging. I am using the Cadwell. That is a new tool merging EMG function and ultrasound. And this is a new one, so probably we can improve in the future. The setting can be improved, and we can see better also the very small branches. And now we are seeing here. Here is a branch, you see. These are the fascicles, and this is the artery. We are in the palm. You see the different fascicles. Here they are becoming digital nerves. And I would like to show you that we are able to see also the digital nerves. Here is a case. Posso? Here is the case of post-surgical hypoesthesia after tendon surgery, and the patient complained of hypoesthesia in this region, so one digital nerve or the ulnar nerve, and we evaluated in longitudinal view the nerve in transverse canal. We said to the surgeon, be quiet, no problem to the nerves, is not with the neurotmesis, but he didn't trust and he explored, and the nerve was really in continuity. There is a question? No, troppo. No. Okay. Do you see the OBS now? Is
no, sotto, se può mostrare il branchio all'ultimo.
Yes, absolutely. We will show the brachial plexus. We start from the main nerves, but we have time also to show the brachial plexus. So this is the median nerve and the main course. Obviously, it's crucial. Although the carpal tunnel syndrome, it's very easy to diagnose with EMG. Often we speak about carpal tunnel syndrome, although we don't see the compression of the nerve, and it should be better also see the nerves. Otherwise, we can misdiagnosis other condition as carpal tunnel syndrome. I would like to show you a case. Vado? So, this is the typical compression of a nerve, where the nerve is compressed with the cross-sectional area small. This is the cross-sectional area. This is the bigger cross-sectional area with a hypoechoic nerve, and this is normal. So we are here, the longitudinal view with the compression, and here is the neurophysiological evaluation of a patient with a typical carpal tunnel syndrome symptoms. This is the median nerve, this is the first digit median nerve, and as you can see, the third digit wrist median segment is not so clear. The response is polyphasic, but we can obtain the similar responses. This is the fifth. Without ultrasound, I can only say that we have one branch more involved, the third, the branch going to the third digit. But by using the ultrasound, we can say there is a bifid median nerve, and we can also add, pay attention, it is not suggested endoscopic surgery, because the endoscopic surgery in presence of bifid median nerve, we may have major complication with cut of one branch. This is another case. Look at this. This is the nerve dividing into two branches, the bifid median nerve, but between the two branches there is hypoechoic structure that is a muscle, is a palmaris reversus, is a anatomical muscle anatomical variation. So also in this case we provided information to the surgeon, and we said, pay attention, you have to open release and to cut the palmaris reversa, that is a vestigial muscle. Okay, let's go to the ulnar nerve. We put the probe here in the mid forearm, and we see a muscle that is the flexor carpis ulnaris. Do this movement. Okay. And under the flexor carpis ulnaris, we see something that should be the nerve, because with the black dots that are fascicles, and we can follow distal close to the artery, and we are going toward the Guyon canal. Here is with a triangle shape, and we are going into the canal, Guyon canal. Pay attention to modify the angle in order to continue to see the nerve. Here is the bone and the osteofibrosis ring of the Guyon canal. But take a look at this. Here we have part of the ulnar nerve that are detached, and they are going dorsally here with 4 fascicles. 1, 2, 3, 4. Now they are within the ulnar nerve, and now they are detached. And this is the dorsal branch of the ulnar nerve. You can see on the probe that we are going in the dorsal part of the hand, on the region, on the ulnar region. So here is a clear example on how can you follow the branches when they detached, when they born from the main nerve. So again, and now we know that this fascicle will become the dorsal cutaneous branch. Here is, okay? This is a good point to evaluate an ultrasound tool. If you see very well and you can depict the single fascicles, it's the setting and the probe is quite good. If in the best setting we can also follow distal until the 5th digit. So going back to the ulnar nerve, we can follow at the elbow. Here the nerve is you can see that this is the flexor carpi ulnaris, and you see that the flexor carpi ulnaris is dividing into 2 tendons, because this is the arch formed by the 2 tendons, and here we have only the tendons, and now the nerve is going into the groove. Okay, and now I need more gel. I can study the ulnar nerve into the groove. Here is the elbow, this is the bone, the medial epicondyle, then the nerve, the triceps brachii, and here is the ulnar nerve in the arm. And if you remember, now we will see also the median nerve. This is the median nerve, and this is the ulnar nerve. Okay, going back to the elbow. Here is within the elbow, and here is with the 2 tendons of flexor carpi ulnaris, and here is under the muscle, flexor carpi ulnaris. And it's very useful to evaluate also dynamically the ulnar nerve within the groove. And we see the nerve within the groove. Here is the triceps. This is the nerve. And I can measure the cross-sectional area with the ellipse or with the trace. 9 millimeters square, absolutely normal. Ok? So, se passiamo al PowerPoint. This is the condylar groove, this is the nerve, this is the triceps, this is the medial epicondyle. And sometimes we may have, during the flexion, the medial head of the triceps may push the nerve above the medial epicondyle. Look at this. You see, above the medial epicondyle. During a dynamic evaluation, during flexion of the elbow. But sometimes you may also have a complete laxation of the nerve. Look at this during the flexion. Whoops, on the other side. Okay. And this is the sensitivity of neurophysiological evaluation by using the traditional, the conventional tests. And this is the sensitivity of ultrasound. And when you merge the two sensitivities, you reach 97%. This is a case in which a patient complained of pain in ulnar region after transposition. The surgeon didn't trust the patient. I put the probe and I'm sorry, this way I cannot show you very well because I can't, okay, non funziona. Here is the nerve, you see larger cross-sectional area hyperechoic, and here is during the flexion, here is the nerve above the medial epicondyle. That's why the patient complained of pain, and the surgeon absolutely trusted in my WhatsApp video and operated on to complete the transposition. Okay, we have other cases, but move on to the brachial plexus. Questions?
No.
No. We can study obviously only what the nerves above, not under the bone, so supraclavicular space. This is the brachial plexus. Arranging the brachial plexus into roots, and we can study the roots on the basis of the anatomical shape or the vertebrae in which the root is going here. Here is the C6 because it's like a large U shape, and then you will see smaller V shape, C5, and here C4, and going back, here, but not well depicted, we have C8 because it is flat. And all the plexus is here, and we can freeze, and we can do okay. 78 millimeters square, absolutely normal. So you can study the brachial plexus, and this may be very useful. Se mettiamo il PowerPoint. You know that it's very complex to study by using EMG, the brachial plexus. Look at this case. In emergency room, or sorry, in intensive care, I saw this case 5 days after the trauma, motorcycle trauma, and I studied, the patient had limb plegia, upper limb plegia, and in longitudinal view I saw a root with a wavy course, and I suspected stretching and neurotmesis, and these are the roots, and you see disappearance of 1, 2, and 3. So in these cases, 5 days after the trauma, without MR, we were able to suggest plexus reconstruction. This is another case, bicycle accident, plegia of deltoid, and weakness of biceps brachii and brachioradialis. Look at this. You will see 2 roots, 1 and 2. This is the C6 roots, and you see that is with the enlargement consistent with the biceps brachii and brachioradialis weakness, but the root C6 was in continuity. Look at the other roots, C5, disappearance and appearance with a neuroma. So, consistent with the plegia of deltoid, not due to the circumflex nerve, but axillary nerve, but due to the C5 discontinuity due to the stretching. So, C5 and C6 had stretching, one with a mild damage and neuroma, the other with a neurotmesis. This is C5 and this is C6. Okay? You have to know, you probably know that by using EMG we are not able at all to distinguish between axonotmesis and neurotmesis. Although we should know because they have a completely different prognosis. Questions?
No.
Okay. I would like to show this case in which we are able to see neurotmesis of peroneal nerve and reappearance. This is the sural nerve. This is the peroneal nerve. Only by using nerve ultrasound we are able to do the appropriate, correct diagnosis for the best therapy, for the best indication. I think we can move to the inferior limb and look at the sural nerve. Forse hai detto di mettere al contrario? Beh, però non è che... Ok. Let's start from the peroneal nerve. We touch and we look for the fibular head and put the probe, and we see the fibular head and the peroneal nerve, the fibular nerve. You see here, you see how close is the fibular nerve or peroneal nerve to the fibular head. That's why in case of a fibular head, we may have damage of the peroneal nerve. The distance between the nerve and the bone is 1.2 millimeter, and the cross-sectional area of the peroneal nerve is 12. Really, it's just a little smaller because this is just a little bit too large. But in any case, we can see the nerve. And what is this? This is probably the sural nerve that you know that is formed from the peroneal nerve and tibial branch. Let's look at the course. Yes, it is the sural nerve branch. I need the gel. So again, peroneal nerve and few fascicles detached from the peroneal nerve, and we follow. And you see that is absolutely in the region of sural nerve. Here, okay? You have to be able to recognize, to put the probe and look and see the. If you don't trust me, we can follow. Go proximally, and if is going within the peroneal nerve, we are in the right, identifying as a sural nerve. So I was right. Here is going distally. You see fascicles. Obviously, the nerve is becoming smaller because some branches are innervating the sensory region of the sura. And the peroneal nerve, we can follow, and we see this is going deep, and is merging with this, that is the tibial nerve. If you want to be sure that is the tibial nerve, you follow distally, and it is the tibial nerve. You see? Do you see how is much clearer changing the angle? Okay. Which question?
How to difference between neurotmesis and axonotmesis by ultrasound?
Because you see, ritorniamo al...
Oh, fine.
You see the discontinuity of the structure. This is the nerve disappearing and appearance again. Or in the longitudinal view, with a stump interruption, or in this case, neuroma, this is the peroneal nerve, neuroma, interruption, no continuity of the nerve. Let's look another case. After external fixation due to humeral fracture, look at this. This is the radial nerve. Disappearance of the nerve. Okay? Going back to the this is the tibial nerve, and we can follow the fibular and is merging with the tibial. I can follow the tibial distally. Here is. And is becoming smaller because it's giving branches to the gastrocnemius and so on. Okay? I would like to show you also other model, other images from from a girl. Ginevra, Ginevra, Vincenzo. Thank you. Otherwise, you can think that only the nerves are, we can visualize, and they are clearly visualized only in some patients, but it is not. Only in obese patients we may have a problem. Here I put the probe in the forearm, and immediately I see the median nerve, the surface, the superficial flexor digitorum, and the deep one. So this is the median nerve. We can follow. We can follow, and we are going into the carpal canal, tendon, and the median nerve. This is the site when the nerve is enlarged in case of carpal tunnel. Okay, let's have a trace. Okay, 9 millimeters square, absolutely normal. Lisa Hobson-Webb and me simultaneously, many years ago, we were assessing the ratio, wrist-forearm ratio. And we said that the normal ratio between forearm cross-sectional area and wrist is 1.4. Absolutely the same results in two different part of world. This is a more sensitive method to study to assess the enlargement. So in this case, we can use ellipse. Okay, 5, so absolutely normal wrist forearm ratio. I said that the median nerve at the elbow is less well depicted. Not in this case. It's very well depicted also under the lacerto fibrosus. And here we are in the region where we spoke about the small distance between the humerus, the supracondylar part of the humerus, and the nerve. You see here is less than 2 millimeters distant. But here we have a muscle between the two structures that protect the nerve. But another very risky position for the nerves is the radial nerve at the mid-arm. Here we see the radial nerve in the elbow with the two branches, and you can identify the two branches here. They are detached, and here you can see the posterior interosseous nerve here. This is the supinator muscle. So now we are distal to the Froese arcade, and we can follow the posterior interosseous nerve. Now we have both together, the superficial one, and now we are going to the arm, and here the arm is in the arm. The nerve is close to the bone. Four millimeters square. No distance between the radial nerve and the humerus. Okay, very risky position. Again, we can try to follow the superficial branch. Here is. I need more gel. You know the course of superficial, and it's going very surface, okay, and very close to the radius and very close to the tendons. Here is the branch, here is the branch, the 4 fascicles, 1, 2, 3, 4 fascicles. You see here, and now they are dividing into two different branches. You see here, one is going here, and now the tendon and the nerve are very, very close. You see? Tendon and nerve. That's why in case of tendinitis you may have sensory disturbances in this region, in the dorsal region of the thumb. Question? No. Okay. I think we can stop. We can leave space to the questions. In the meanwhile, grazie Vincenzo. In the meanwhile, I will show you something about the radial nerve. Sì. Ci siamo? No, adesso io che muovo. By using ultrasound, I give you the time to write the questions. In the meanwhile, I show you how the ultrasound can discover new kind of damages and mechanisms. Possiamo mettere in presentazione? No. Okay. Unfortunately, I have not the animation, but in any case, I would like to show you how, in case of a trauma here, we may have a distant, far from the trauma, another site of involvement of the same nerve, where the nerve is fixed under the tendons or in an arcade as the Frost arcade. What does it mean? That in case of humeral fracture with the involvement of the radial nerve here, we observed that we have involvement of posterior interosseous nerve here in the Frost arcade, distal from the trauma. The first time we observed, we said, oh my God, we have another site of lesion far from the trauma. And then we started to study many cases of radial nerve involvement due to humeral fracture. And here, if you remember the images of the posterior interosseous nerve of Vincenza, you may have normal PIN on the one side and larger PIN on the traumatic side, far from the trauma. So 50% of the patients with radial involvement due to humeral fracture may have also posterior interosseous nerve involvement. This is not unusual, not only in the radial nerve. So the ultrasound was able to show another kind of lesion related to the trauma, but far from the trauma. Questions? We wait for a few minutes, otherwise we close the workshop.
No more questions.
No more questions. So I think that we can stop the workshop, and good luck and welcome to the ICCNMI society that we founded in 2012, and we had in Rome the first meeting, and now we are far from the first meeting, and we are proud about the job of the society and how we are connected among different disciplines, rheumatologists, physiatrists, neurologists, neurophysiologists, and so on. All of us involved in improving the nerve assessment. So, bye-bye.